Okay, good afternoon, everyone. We are coming to you live from the University of the Philippines, Manila, for the Dr. Lourdes Manahan Lectures in Rheumatology. This is the third installment of a four-part webinar series that we hold every 2 weeks. I am Dr. Ester Gonzalez Penserga, Professor of Medicine in the Division of Rheumatology, Department of Medicine, University of the Philippines, and the Philippine General Hospital. I am the moderator for this session. This week's webinar focuses on the management of osteoarthritis, which is the most common arthritis among Filipinos and in the world for that matter, with special information during this COVID season. So now let's go to the housekeeping rules first. If you can see, you're all muted, and you are therefore encouraged or asked to write your questions or reactions in the Q&A box, and we shall address them during the open forum after the lecture. Likewise, you will receive your certificate of participation to this webinar through email after you fill up and submit the evaluation form and the post-test. The link will be posted in the Q&A box just before the end of the webinar. Now, the Lourdes Manahan Lectures in Rheumatology is an annual event hosted by our division in honor of the first Filipino rheumatologist, Dr. Lourdes Aguirre Manahan. This year is the 17th year of the LMLR. And it is really a special year because this year is Dr. Manahan's 100th birth anniversary. Dr. Manahan was in many ways a special lady during her time. When she was an intern, she wrote with her resident the Rotor Manahan syndrome. And that was in the 50s yet. She then set off to America to train under the great pioneers of the then fledgling field of rheumatology. And most of all, she came back. She came back to establish the first practice of rheumatology in the Philippines, and also together with a few physicians here in the country with special interest in the musculoskeletal diseases, they founded the then Philippine Rheumatism Association in 1964, the forerunner of the current Philippine Rheumatology Association. Let us all remember that in these halls of the Philippine General Hospital was born the subspecialty of rheumatology. At this point, I am happy to introduce our special guest. He is Dr. Juan Javier Lichalco, current president of the Philippine Rheumatology Association, to welcome us. He is assistant professor of the St. Luke's Medical Center College of Medicine and is the head of the 2 rheumatology centers of St. Luke's Medical Center in Bonifacio, Global City, and in Quezon City. Dr. Lichalco, we welcome you.
Thank you, Dr. Penserga, and a pleasant day to all. I would like to welcome everyone to the Dr. Lourdes Manahan Lecture Series in Rheumatology. Hearing stories of Dr. Manahan from those who were fortunate to have experienced life with her describe her as a remarkable woman. Among relatives and friends, she was the go-to person who always gave sound advice. She was a woman of unwavering integrity and honesty, and as a physician, she has long possessed the attributes of what has been called a 5-star physician. Beyond being an astute clinician who always prioritized the welfare of her patients, Dr. Manahan was an emulated educator who led by example and, in the true sense of the word, served as a mentor for countless aspiring physicians. She was an ardent researcher who tirelessly collected her own database of patients, leading to publications and a syndrome named after her, the Rotor Manahan-Florentin syndrome. She was a leader and trailblazer who, after presenting her paper on rheumatic diseases in the Philippines in Australia, was inspired to plant the seed and spearhead the formation of an organization to address the needs of Filipino patients with rheumatic diseases. The Philippine Rheumatism Association was established in 1964, and with only a handful of trained rheumatologists that included Dr. Clemente Amante and Dr. Tito Toralba, it was a daunting task to care for thousands of patients and promote the field of rheumatology. At present, the Philippine Rheumatology Association, or PRA, has grown and is comprised of over 200 members. The organization continues to build on Dr. Manahan's legacy. Through its accredited training institutions, the PRA ensures to provide competent and compassionate rheumatologists to fill the unmet need of patients with rheumatic disorders. But apart from promoting advances in therapies and enhancing our academic and clinical research in rheumatic diseases, we continue to strengthen our collaboration with primary care physicians and specialists through various educational platforms. And the PRA has engaged with various support groups and continued to work on influencing healthcare policies for the welfare of our patients. There is still a lot of work ahead of us as our tribe continues to grow, and I cannot thank Dr. Lourdes Manahan enough for leading the way. I would like to end by sharing a quote of Sir William Osler. He said, "The practice of medicine is an art, not a trade, a calling, not a business, a calling in which your heart will be exercised equally with your head." It is but fitting to remember the life of Dr. Lourdes Manahan and to celebrate the qualities of a good human being that are truly inspirational and aspirational. Maraming salamat and a good day to everyone.
Thank you very much, Dr. Lee Chowkow, for that heart-tugging description of Dr. Lourdes Manahan and for being here with us on our third series of lectures. Thank you very much, Dr.
Thank you.
Chowkow. So now, before calling in our speaker, let us first thank our sponsor, Mylan Philippines, for making this webinar possible. We also thank the more than 100 participants, or more than 200, almost 200 attendees now, for coming over to attend. Now, our speaker is Dr. Geraldine Tong Zamora. She's a multi-awarded physician at this very early age and young age and early time of her practice. She graduated from the University of the Philippines College of Medicine, where she is now faculty. She is actively engaged in practice, advocacies, and also research. Although her current interests lie in vasculitis and lupus, one of her first few publications were on osteoarthritis, and she wrote clinical profile of Filipino patients with osteoarthritis seen in local tertiary centers. So let us now call in Dr. Zamora's lecture entitled Refining the Management of Osteoarthritis. Jean?
Thank you, Dr. Penserga. So this talk is to redefine management of osteoarthritis, and I will do so with special emphasis on the COVID-19 pandemic angle. These are my disclosures. And after this talk, my objectives would be for the audience to be able to discuss updates on the management of osteoarthritis and to apply strategies to promote to their patients, especially during this pandemic. Just a little bit of history, since osteoarthritis is by no means a new condition, nor are we the only species to be afflicted by it. This is a 150 million year old dinosaur fossil discovered by a team of researchers from the United Kingdom, which displayed an arthritic-like condition, much like many other dinosaur species, which had osteoarthritis of their ankles. And fast forward to present times, osteoarthritis remains the most common cause of joint pain, affecting 7% of the global population, an estimated 500 million people worldwide, with women disproportionately affected by the condition. And while older age is the greatest risk factor, it is now realized that osteoarthritis is not an inevitable consequence of aging, and that it results from a complex interplay of factors, including joint integrity, local inflammation, mechanical forces, genetic predisposition, as well as cellular and biochemical processes. This is a slide from Dr. David Hunter in one of our Asia Pacific conferences regarding the relationship of mechanical processes such as obesity with osteoarthritis, especially of the knees. And this is especially relevant now because many of us and our patients have reduced physical activity and may have worse diets due to the quarantine. In this pathogenesis of osteoarthritis explained by Dr. Penserga in her review article a decade ago, the interaction of the cells in the subchondral bone, synovium, and cartilage create a cytokine network that tip the balance towards pro-inflammatory processes. And this is what we call the cytokine soup. And it includes several pro as well as anti-inflammatory factors. Therefore, osteoarthritis is a disease that clearly shows the cytokine footprints of active cellular and tissue reaction instead of simply just being a wear and tear phenomenon. So we've known this for quite some time now. Osteoarthritis is characterized by pathology involving the whole joint, including cartilage degradation, bone remodeling, osteophyte formation, and synovial inflammation, leading to pain, stiffness, swelling, and loss of normal joint function. So the hands are one of the most common joints affected, also the knees. Although knee osteoarthritis is more disabling and clinically significant, while hip osteoarthritis is rare among Asians, but more prevalent among the whites. Osteoarthritis was foreseen in 2003. This was this was from Time magazine in 2003, and it was foreseen to be an epidemic. And now, 17 years forward, aside from the COVID-19 pandemic, we are already living in an arthritis epidemic. And one of the goals of modern medicine is to extend the quality and years of activity of the population affected by cartilage lesions and osteoarthritis. Unfortunately, articular cartilage lesions with their inherent limited healing potential are hard to treat and remain a challenging problem, both for physicians and patients. The regeneration capacity of cartilage is limited because of its isolation from systemic regulation and its lack of vessels and nerve supply. And unlike most tissues, none of the inflammatory processes is available for its repair, and the chondrocytes cannot migrate from an intact, healthy site to the site of injury. Okay, as osteoarthritis spans decades of a patient's life, patients with osteoarthritis are likely to be treated with different drug and non-drug interventions, often in combination. And these are just 4 approaches considered vital in the 2019 American College of Rheumatology and Arthritis Foundation guideline for the management of osteoarthritis. So these include physical, psychosocial, mind and body, as well as pharmacologic domains. The first 3 approaches that are recommended are presented here, and strongly recommended are exercise and self-management programs for all, weight loss, tai chi, and use of cane for knee and hip osteoarthritis, the use of first carpometacarpal orthosis for hand OA, tibiofemoral knee brace for knee OA, and conditionally recommended are these on the screen. So balance training, yoga, acupuncture, behavioral therapy, and such. Pharmacologic approaches are also presented as follows. NSAIDs are often used, oral as well as topical, intra-articular steroids, acetaminophen, tramadol, duloxetine, chondroitin for hand OA, and topical capsaicin for knee osteoarthritis. These are therapies recommended against OA, although let me remind you again that this is from the American perspective, and my next slides will show a European point of view. So strongly recommended against include the DMARDs, such as hydroxychloroquine, methotrexate, and very important to point out, since there are several enterprising businesses promoting these, the use of stem cell therapy and even PRP for osteoarthritis have still not yet reached very good results in some of the studies that we've seen. And aside from non-pharmacologic or pharmacologic approaches, these are some non-pharma therapeutics that may be recommended against, but you will see in my next slides that there's actually some contradictions in these guidelines. It depends on which part of the world these guidelines are coming from. So this is from the SK, or European recommendations for osteoarthritis and osteoporosis. The recommendations include the basic principle of a combination of non-pharmacologic and pharmacologic management with a core set of education, weight loss, as well as exercise program. If a patient is in pain, paracetamol or a Cisadoa or symptomatic slow-acting drugs in osteoarthritis may be prescribed. So these include glucosamine sulfate and or chondroitin sulfate as needed, with or without paracetamol. And if still symptomatic, topical NSAIDs or topical capsaicin is recommended. A referral to physical therapists may be needed, or in fact, it's always needed, so that we can help patients in case they have malalignment, they may have a need for knee braces or insoles, and these may be added at any time as needed. So walking aids, thermal agents, manual therapy, acupuncture, and even TENS, or transcutaneous electrical nerve stimulation. Next slide would show the advanced pharmaceutical treatment in persistently symptomatic patients. So these include NSAIDs and even intra-articular hyaluronate and corticosteroids. If still refractory, opioids may be used, as well as duloxetine as in the American recommendations. And end-stage management, of course, is surgery. So the last 3 slides are from Dr. Monsanto, our fellow in PGH. Okay, so I just wanted to show this Philippine CPG for knee osteoarthritis, number 8 and number 9 in that guideline regarding the use of glucosamine, because there might have been confusion in the audience because the American guidelines do not promote it, but the European ones do. In the Philippine guidelines, the use of pharmaceutical grade glucosamine sulfate is recommended for its small benefit on pain reduction and improvement of function in patients with knee OA. However, the use of glucosamine hydrochloride is not recommended because the latter one is what is mostly available over the counter in the United States. So we have to remember that if we'll prescribe glucosamine to our patients, that we have to do so using glucosamine sulfate salt. Okay, so we know all those guidelines, but now what happened during this pandemic when we had to be in lockdown and extended community quarantine, how do we now manage osteoarthritis, or how do we help our patients manage their osteoarthritis during these times? Okay, as osteoarthritis affects more than 80% of people older than the age of 55, an age burden also shared by COVID-19 patients with the highest severity. And because osteoarthritis patients often have concomitant comorbids such as diabetes, cardiovascular disease, these may therefore increase complications. And aside from that, the different osteoarthritis treatments such as NSAIDs, paracetamol, steroids may have a wide array of iatrogenic effects, potentially increasing COVID-19 secondary infection incidents or complications. Several studies have tried to determine potential roles of these drugs that may be used in osteoarthritis during this pandemic. And fortunately, until present, none has shown evidence that NSAIDs, paracetamol, steroids, and even opioids should be discontinued simply because of an infection or because of the pandemic, unless, of course, there's another contraindication. But of course, these still have to be used with caution. For example, NSAIDs and paracetamol do not increase infection risk, but they can be responsible for a later presentation of symptoms because the fever will not be present or will not be visible to the patient. There might be an underestimation of the severity of the disease, and this would lead to a delayed diagnosis and possibly a worse prognosis. Steroids, as we know, may increase the risk for infections, but this is also being used in our patients with COVID. And opioids should generally be prescribed with care because they also interfere with innate and acquired immune responses. These may depress the respiratory system and increase the incidence and severity of infections of the airways. To be more specific, this figure shows the escalating phases of disease progression with COVID-19 with associated symptoms and the relevance of osteoarthritis treatment with their possible continuation or discontinuation, or especially in the second column, checking the cost-benefit or the risk-benefit ratio depending on available literature if we want to give these to our patients. Going back to NSAIDs first, there's a recommendation initially at the outset to avoid NSAIDs. This was disseminated in the media in the early weeks of the pandemic based on some experimental results, but this hypothesis was never confirmed. However, there's always been a warning to avoid systemic systemic NSAIDs in patients with osteoarthritis with cardiovascular comorbidities because this exists independently of the pandemic. We all know that NSAID use may account for more than 40% of increased cardiovascular risk in patients with OA. So therefore, they should be used on demand for the shortest period possible, restricting naproxen given its less deleterious cardiovascular risk profile. Moving towards actual management, this article provides evidence-based recommendations summarized from 33 eligible studies for patients with severe knee osteoarthritis who had their knee surgery postponed due to the COVID-19 pandemic. And management is performed at home and consists of exercise, proper nutrition, physical therapy, and use of corrective and assistive orthotics. Clinical guidelines suggest that exercise is the primary non-pharmacologic treatment of knee osteoarthritis. The most common types of exercise used for treating knee OA are low-impact aerobic exercise like walking, although cycling is preferable. Resistance training in combination with range of motion activities are also indicated. The range of motion exercises may be done 5 to 10 times each day and best in the morning when the joints are still stiff. So we just have to ask our patients to move their joints throughout the whole range of motion, whether it be the knees or the shoulders or the other joints. No? So gagalaw lang siya from end to end, at least 5 to 10 times each day. So these will be very helpful, especially for morning stiffness and for preventing contractures. There is sufficient evidence for pain reduction and physical function improvement. And I also want to share at this point that one of my patients said that physical activity sounds better than exercise because they said allergic na sila sa word na exercise. So we may actually tell them to just be more active and not necessarily tell them to exercise. And we should also remind them to limit movements that cause extra pain and axial joint loading. So exercise benefits patients by inducing muscular hypertrophy and strengthening and increasing blood flow as well as joint lubrication. The optimal combination still remains uncertain with no type of exercise shown to be better than another, but mixed programs are recommended when it comes to the type of exercise. Quadricep strengthening as well as that of the hip and the lower limb muscles and aerobic training all have favorable effects regarding pain and knee function. The resistance can be as simple as lifting a limb against resistance or against gravity, or using handheld weights or elastic bands, or simply pushing and pulling stuff around the house or what's available in the house. So what I usually tell my patients, for example, they're just watching Netflix or TV or YouTube, if they're seated, they just get a bottle of water, a mineral water bottle, They just fill it up with water and use it as weights. And as they grow stronger, they can change their 500 ml bottle into 1 liter bottle, and then 2 liters, and so on. So they don't exactly have to buy gadgets for them to be able to increase their physical activity. Even movement against water can provide resistance when done at faster speeds. Unfortunately, not everybody in the Philippines has a pool, but for those who have, there are many pool-based physical activity videos that we can see online, and we just have to find the right one for our patients. Exercises should incorporate progression over time, and then these are what we can advise our patients to avoid. Running on hard surfaces, jumping, stair climbing, if this can be avoided, and squatting. So these should be limited. And the exercise regimen may be adapted according to the pain experienced by the patient as well as their functional limitations. Okay, so during this pandemic, our patients with knee OA, and even us, mostly stay at home, except when we're in the hospital. So we should therefore pay special attention to our weight. So hindi lang their weight, but also our weight. There's evidence that for each kilogram of weight loss, the knee experiences a 4 kilogram reduction in load per step and a 4,800 kilogram reduction in compressive load for each kilometer walked. And this is important, especially in the long run, because diba, ang sabi nga sa atin, we should have 10,000 steps per day. So if each step will be reduced by 4 kilograms, then that's going to be significant, especially in the long run. Individualized diet interventions with weight loss goals and involving regular follow-up to assess progress have been associated with pain and functional improvements, especially in patients who are overweight with knee osteoarthritis. And this is from a meta-analysis of 5 trials. It's demonstrated that there was a significant reduction in disability when weight was reduced more than 5% over a 20-week period, or at the rate of 0.25% reduction per week. So this simply means that if you are 100 kilograms in weight, just aim for weight loss of more than 1 kilogram per month within 5 months, and there would already be significant decrease in disability. So this is probably a less daunting goal for our patients to think about. 1 kilogram per month, that's actually quite doable if we put it in this perspective, and we let our patients see it in this perspective. Physical therapy, symptomatic patients suffering from severe end-stage knee OA may benefit from a referral to physical therapists for video instructions and supervision. And we have several rehab doctors here who are available for tele-rehab. These supervised sessions have been shown to act favorably on patient adherence to home exercise programs, which may result to less pain and improved functioning. And there is little evidence to support the use of thermal packs or ice packs. However, due to the fact that they're accessible and affordable to most patients, thermal modalities are included in OA treatment guidelines for managing pain. So heat may be applied through warm water packs or heat packs and could be used at the same time as stretching during painful episodes. And cryotherapy is typically implemented with ice packs for managing acute episodes of inflammation and pain. So we should remember that while osteoarthritis is a chronic condition, there will be times that our patients will have more inflammation than normal. For example, some of my patients would say nag-Zumba sila the other day, and then the next day, their knee is already more painful and more swollen. So this is where ice packs may help. Knee braces are designed to alter contact pressures, especially with unicompartmental knee osteoarthritis, by exerting either a valgus or a varus force. And these can improve stability, reduce muscle contraction needed to stabilize the affected knee, and minimize the risk of falling. There is improved pain scores and walking tolerance at 1 year. With knee offloader braces, especially if it's in the medial compartment type of osteoarthritis. However, more high-quality studies are warranted to check which subset of knee osteoarthritis patients are likely to benefit from knee braces as well as orthotics. So these are also very expensive. I think they're in the range of 20 to 50K, no? Because I asked before in one of our conferences. Appropriate footwear is recommended in every patient with osteoarthritis, especially knee OA. It has been demonstrated that the use of shoes or insoles with shock absorption for a month reduced pain and improved functioning. This is something that we can tell our patients and advise them. Shoe requirements include shock absorbing soles, support for the arch, and no raised heel, and a size big enough to give space for the toes. While in patients with medial knee osteoarthritis, lateral wedge insoles may reduce pain and improve ambulation by reducing knee adduction movement or moment, and therefore this may decrease joint stress. Okay, so studies are still controversial, but theoretically, they should help contribute to lessen joint stress. So at this point, I'd like to ask the live poll questions to be flashed. I have 2 for you. I hope you can answer them. This is the first one. If a patient has right knee pain, which hand should you advise your patient to hold the cane with? So is it A, contralateral? So if the patient steps with the right knee, nandun yung pain, the cane with the left, the left hand holding the cane will step as well. So that's A. Or is it B, ipsilateral? Your right knee, which is painful, the right leg will step with the cane on the right hand. Or C, ang gulo ko. Or C, both, no? We should suggest a walker instead. So can you please submit your answers? Saan hindi ko kayo nagulo sa explanation ko? So is it contralateral, ipsilateral, or walker na lang? Okay. Let's wait for the answer of the audience to the poll. You can actually just tap that. Okay, so majority, but it's a close count. Ipsilateral with the right hand versus contralateral of the right hand. So I will discuss the answer after this. Next poll, please. Can you please flash the next question? There. If a patient with right knee pain will go down the stairs, so this is assuming your patient can only do one step at a time, yung bababa yung isa and then the foot will follow. Hindi yung parang step by step may bababa. No? So if a patient with right knee pain will go down the stairs, which foot should go down first? Is it the left, yung hindi masakit na tuhod, na leg, or the right? Can you please click your answer and submit? And then let's see the result or what we think about the question. Okay, so majority of the audience replied left. So pag masakit daw yung right knee, we go down with the left foot first. Okay, so you can close your poll questions now and I will proceed with explaining the answer. Okay, ito pala yung live poll. Okay, there. So walking aids and assistive technology at home should be considered as a safe alternative and play a crucial role in patients with knee osteoarthritis since the value of these measures has an immediate impact on individual patients. So this is also something we can teach even through teleconsultations. Canes are affordable means to unload the affected joints. They also help provide stability and potentially reduce pain. And patients should be taught the optimal use of a cane or a crutch in the contralateral hand. So if there is right knee pain, the left hand will hold the cane and dapat isabay yun step. So the right foot will step kasabay ng left hand with the cane so that the left upper extremity holding the cane will help take the weight of the right knee when the right leg is stepped. Nagets nyo ba? So dapat sabay yung right leg and the left hand with the cane para mabuhat ng left arm yung weight from the right knee. Okay, so this is a common mistake that I also see in my patients when they go to the clinic before the COVID. They would use their cane on the same side of the painful leg. So mas magandang sa kabilang side. Okay, so I hope this is something you can teach your patients also moving forward. Wheeled walkers are ideal for those suffering from bilateral pathologies and are suggested for patients who require maximum assistance, particularly for the elderly. And it's a requirement for patients to have good strength bilaterally, good arm strength rather, so that they can help support the weight and offload their knees or ankles and hip. Okay, so before we move from this, I really hope you remember this part. No? The cane or the crutch should be on the contralateral side of the painful leg. Ito naman, we can also teach our patients the best way to go up and down the stairs because some of them cannot do without going up or down the stairs. For example, their room is upstairs. There's no option to sleep in the ground floor or merong talagang steps to go up to their house. Okay, so if there is leg injury or knee osteoarthritis, you want to use your strong side to do most of the work. So I use the up with the good and down with the bad. This is what I always tell my patients so that they also remember. When going up the steps, you want to step up with your uninjured side. So your quadriceps muscles can power yourself up. No? You can power you up. No? Siya yung talagang mag-work para maitaas ka. So this is when using a step to approach, yung paisa-isa lang, hindi yung bawat step aakyatin. Because this is what our patients with painful knees might end up doing, yung isa-isa lang, no? Okay, and then when you are going down, you want to lead with your injured side or painful side. And this is because when going down, the leg staying on the step, yung naiiwan, is doing all the work in an eccentric contraction. Actually, eccentric contractions are stronger than concentric contractions. No? They require more strength. So, kailangan malakas yung maiiwan because otherwise, it can buckle and the patient can fall. So, up with the good and down with the bad. And if a patient has right knee pain or right leg pain, mas magandang bumaba with the right leg because it's the left quadriceps which is trying to lower you down dahan-dahan in an eccentric contraction. Okay, next slide. I skipped this. So I just wanted to show the systematic review in 2017. This was still pre-COVID, and this included 7 randomized control trial studies with no or other interventions regarding pain, physical function, and health-related quality of life in patients with OA of the knee. And it showed favorable effects. And this is just one of the forest plots. There were quite a lot, but I don't have a lot of time to discuss this here. And here is the article, the author and the article name. You can also look it up after my talk. These effects may be too small to make relevant differences for individual patients, but we have to take into account that the balance between benefit and harm, the magnitude of effects, and now that we're in this pandemic, this may be important for us to revisit now, no? Electronic health-supported home exercise interventions for our patients. Okay, given also that exercise and weight management are the only hope for managing symptoms of the disease, exercise as a core treatment, irrespective of age, comorbidity, pain severity or disability, is also mainly advised in this article. And there was worldwide closure of gyms and pools and parks. So this means that we really have to advise our patients to keep moving and to exercise at home or close to home. For example, they can just walk in the living room. And this article talked about yoga, tai chi, that they can do at home, Pilates, and even chair-based sessions. And these are searchable in YouTube. There are many YouTube videos of these exercises. Some gyms do streaming services for fitness classes. And it's even said in the article that even the old Nintendo Wii Fit balancing board, which is just gathering dust in the storage, may come in handy. So we have to give them ideas how to strengthen their muscles and how to do all these amidst the pandemic, and not just tell them, oh, you have to lose weight, you have to exercise. Hindi lang ganon. It's better if we can give them concrete examples. Even as simple as raising the, di ko pala nalagay dyan, yung raising your, or extending the knee while seated and watching TV, and have them count 10 seconds at a time. So they just raise the foot and extend the knees while watching TV for 10 seconds at a time, and then repeat lang many times. This will already contribute to strengthening of their quadriceps muscles. So yun, we have to help them think about ways on how to increase their physical activity. And yun nga, as patient said, medyo allergic sila sa word na exercise. So we can tell them, for example, if they're brushing their teeth, they can squat a little bit. No? When squatting, patients should avoid squatting more than 90 degrees of flexion of the knees, just so it's not going to be very tight. But they can do a simple mini squat while brushing their teeth. That also helps with stability and balance, aside from strengthening their quadriceps muscles. This is an opinion article published 2 months ago, and it also suggested strategies for pain relief and symptom prevention in patients with osteoarthritis during the COVID-19 pandemic. So physical activity is a must, regardless of age. Rheumatologic organizations should be stimulated to develop home-based supervised exercise programs. We have to keep physical distancing as long as needed, and nutritional requirements should be adjusted to the degree of physical activity. NSAIDS should be taken with higher scrutiny. Opioids should not be taken. So as I mentioned earlier, different strokes for different folks. Some people, we really need opioids, but we have to just be careful when we give them. If indicated, we consider intra-articular steroids and hyaluronic acid in the appropriate setting. Important psychological care may include medications or counseling, and information should be disseminated to healthcare professionals in primary care as well, not just among rheumatologists. This article also suggested the following research agenda may be more relevant for us rheumatologists. So we may determine the impact of confinement on OA disability, determine the loss of physical activity in patients with OA during and after the confinement, determine impact of confinement on frailty in the elderly, patient with OA, its influence in mortality in the long term, impact of confinement in OA according to phenotypes, determine impact of confinement in spine OA pain and function. And this one caught my eye, determine safety of intra-articular injections in home care setting. Because I'm not sure if some of the rheumatologists also had requests like this, may mga gustong magpa-inject in the house, no? Or I already was able to inject in the parking lot of the hospital. And there was one time I even had to go to a nearby establishment of a patient because they really cannot or refuse to go to the hospital for the injection. So this is also something we can determine, the safety of such. Okay, so in summary, there are several recommendations in the management of osteoarthritis worldwide, but the most important similarities are the strengths that we can use, we can still utilize even during this pandemic. Virtual education on self-management strategies should be part of coping with knee OA. Initiating an exercise program including gymnastics or stretching, cycling at home, and muscle strengthening. This is highly recommended. Obese patients are encouraged to set weight loss goals and adopt a healthy diet. Potential benefit has been shown for the use of knee braces, orthotics, or cushioned footwear. Walking aids may be prescribed, and when necessary, we should be providing them correct instructions for use. Hindi lang yung, gumamit kayo ng cane, gumamit ka ng walker. We should tell them how to use it properly. Pharmacologic treatment remain the same as pre-COVID. However, we should exercise extra caution on NSAIDs independent of the pandemic simply because of their cardiovascular risks, as well as the other possible risks associated with the use of the other treatment regimens that we can implement on our patients with osteoarthritis. Okay, this is my last slide. We'd like to congratulate Dr. Penserga, our moderator, for being part of the Lancet Osteoarthritis Commission. And future publications would include recommendations that will aim for health, societal and economic benefits, and provide a roadmap from to a world free from osteoarthritis-related disability. So that's the end of my talk. It's 12:45. I think we still have a few minutes for questions if you have some for me, and I'll try my best to answer.
Thank you very much, Dr. Zamora, for that very timely lecture. There was value added, in fact, because most of your latter slides dealt with management strategies during the time of COVID when our patients cannot come to the clinic. So there are many questions here. Some we have answered, but there are at least three here with the same theme. For referral to the rehab specialist or to the physical therapist, are there any special information in order to facilitate? And so also with advice for exercise for stroke patients, and I think patients with multiple comorbidities. How do we manage these in terms of liaising to the rehab doctor?
Okay, so there are several questions to that uh, question, ma'am. No? So let's start with the first one, which is facilitating referrals to our rehab colleagues. It's important for us to be able to tell them the working impression of the patient, no? Not just, for example, referral to rehab. But what I usually do, I always do when I refer to when I refer patients to other physicians, I put their problem lists on the referral letter. So it doesn't just include the musculoskeletal issues that I want them to look into, but also the other comorbids. Does the patient have lupus? Does the patient have stroke? Or the patient has diabetes? Meron ba siyang vasculitis? Because our rehab doctors will also want to recommend therapeutics or management plans based on what the patients can do and cannot do. Even as simple as referring to dermatologists, no, I like, for example, I put their lupus kung talaga may lupus, because some um, treatments may not be parang advisable, for example, laser. So I just did it as an example, but for our rehab doctors and to any other specialist we refer to, it's good to put all the problem lists of the patient and then a special emphasis on what. For example, I asked them if they can help with just the range of motion first, or if they can help strengthen the patient. But more often than not, our rehab colleagues also know better and also know when to add on to our requests. So I think all those are important. It's also good for us to be able to communicate with the rehab doctor that we will who we will refer to. And then in the Philippines, physical therapists are not allowed to formulate their own plans compared to, for example, the US. In the Philippines, it's usually a referral to the rehab doctors, and whatever the plans of the rehab doctor is, he or she will cascade this down to our physical therapist. So it's important to be able to give complete information. And the second question, Doc, is about stroke. Tama po ba?
Yes.
How stroke,
Morbid. And
it was this about stroke in terms of referrals to rehab doctors or stroke in osteoarthritis? Oh, for a stroke patient with a
how
of
we
OA,
can effectively
effectively.
advise
Okay.
exercise.
So if a patient has stroke, and if it's a classic stroke wherein there is hemiplegia, or if there is weakness of one side, we will advise, or we will prescribe management depending on the level of the patient's capability. For example, if it's an acute stroke, it's already something that our rehab doctors and our physical therapists can work on. It can be as simple as range of motion exercises first for the paralyzed part, so that contractures can be prevented and there could be less swelling, because if there is paralysis, you will notice that the extremity also swells a bit because there is no muscle tone. So range of motion exercises, even passively, which can be done by their relatives at home, this can help move fluid back and maintain the range of motion of the joints. As the extremity or the side of the body becomes stronger over time, because there is neural plasticity and a lot of our stroke patients eventually recover most of their strength, we will gradually progress their exercises um, to increasing resistance. So initially, it can just be movement against gravity, and then later on, we can add weights and heavier weights as the patients become stronger. So it's always individualized, whatever the patient has and whatever the patients need. And we can do this with our rehab doctor colleagues. And the third question, ma'am, was in comorbid, how to go about physical therapy for a knee osteoarthritis patient with multiple comorbidities.
Yes.
Okay, it's a referral from the primary physician needed. I saw the question. I think we're referring to comorbidities here that include hypertension. Tama po ba? Yun, for the one who asked, diabetes, the more common ones, metabolic syndrome. Um, Before physical therapy ensues, the blood pressure of the patient is taken. And then as the patient exercises or does physical activity, the BP is also checked by the physical therapist, because sometimes the sessions may have to be cut short or even postponed if the comorbidities are interfering with the rehab session. That's why it's important for us to be able to relay everything that the patient has. Even if it's cancer, yung feeling natin na baka hindi related sa rehab nila, no? They have to know everything because they will also have to watch out for certain scenarios wherein they may have to reduce the intensity of the rehab or to stop it momentarily, or maybe to increase the intensity depending on what the patient has. We can always refer to our rehab colleagues. And maybe the question is also if we should refer personally or if patients can just go directly. I think both can happen. Patients can go directly and consult directly with the rehab doctors because they can be the ones to diagnose what the patient has and they can also be the ones to prescribe the therapy. So I hope I was able to answer that question in the way that I perceive the question to be asked. Yun na po ba yun, ma'am? Yun na ba yung
Jean,
tatlong yun? Yes, ma'am.
there are a lot of very interesting questions. I just grouped these together in terms of questions on drug treatment. There's a
Okay.
comment here from Dr. Merly. Hi,
Dr.
ma'am.
Barba?
So, yes,
Cebu.
yes, from Cebu. She asks for some comments on tanizumab for OA pain.
Mm-hmm.
And if you can, would like to answer that now. And
okay.
There are other questions here on hyaluronic acid, articular installation, viscous supplementation, and also on glucosamine sulfate. Is it safe for the kidneys? So some idea on those, maybe on those three drugs, Jean?
Ma'am, the first one is tanezumab, and then the second one was hyaluronic. Tama po ba?
Yes.
And then glucosamine.
Yes.
Is there
And
another one
then,
po?
ito muna. Ang sa glucosamine is on the side effects. Is it safe for the kidneys?
Okay. Okay, yung sa tanezumab, what I know so far from that is it's an human nerve growth factor. I'm not sure if this is what Dr. Barba is referring to, and it involves small molecules. And this is actually one of the articles that I presented earlier. I just removed it because it's not yet available in the Philippines, or at least I'm not aware of its availability here. But these small molecules are in the pipeline for further studies, and some are already showing improvements in terms of pain. And in relation to COVID, because that's what's in the article, these are still not mainstream enough for us to be able to use or to decide on safely in terms of this pandemic. So if it's available and if it's indicated, then we can try using it, much like the other um, biologic medicines. So I'll read more on that, Dr. Burba, kasi I only saw it a few times. And also I saw it during the ACR, the recently concluded ACR. I saw one abstract on that, and I'll try to look for it again. Regarding hyaluronate, was the question, ma'am, on the efficacy po or on how to? I'll try to see if I can see it. Is it in the
Yes,
efficacy po ba?
indication.
The indication. Normally or usually the hyaluronic injection is indicated especially for patients who are buying time before surgery or for those who cannot really undergo surgery because of many factors, financial, they're too old, they have many comorbids. But in many of the guidelines, this is sort of a bridging or an additional treatment for before surgery. It is in the Philippine guidelines, Philippine CPG. It was indicated that it's better than the corticosteroids in terms of the length of its effect, but just that. Intra-articular steroids and the intra-articular hyaluronate have different effects because the steroids will reduce the inflammation, but the gel, the hyaluronic acid gel, will help lubricate aside from providing an interface against the joint. For glucosamine side effects, there are minimal. It's not shown to have a significant effect on the kidneys and in the liver. It may be something that we can ask help with our nephrologist friends in patients who have end-stage kidney disease, because even if this is just a supplement, there are still molecules there that may be, that the body may be unable to excrete if a patient is supposedly for dialysis, but is not able to do so regularly. But for the general patient without significant comorbids, it's a fairly safe supplement to take. But we also have to remember that glucosamine comes in two forms. There's glucosamine sulfate and there's glucosamine hydrochloride. And some companies write glucosamine sulfate, but if you check the ingredients, it's glucosamine hydrochloride plus sodium sulfate or something like that. So pinapagsama lang nila yung glucosamine sulfate, but the ingredients show that it's glucosamine hydrochloride, which is the active ingredient. And they just added something with the sulfate so that they can write glucosamine sulfate. So let's be wary about those brands.
Okay, Jing, there's a question, another interesting question here. The attendee would like to know your view of acupuncture in pain control in osteoarthritis during this time of COVID.
Okay.
Is it advised?
Okay. Acupuncture has been shown to help with pain, although it will not treat the cause. It does help with pain, and this is already recommended by several in several guidelines. However, in terms of this pandemic, no, kasi you have to have somebody there and tutusok-tusukin ka. Siguro it depends on your own level of comfort. I personally wouldn't want to have it done on me. In fact, even massages na sobrang kailangan ko, sobrang gusto ko na I used to do regularly, I haven't had one simply because I'm afraid. So if a patient of mine would want to have an acupuncture session because of pain or for other reasons, siguro I will throw back the decision to them. But I will explain to them the necessity of making sure that they're protected, their therapist or their acupuncturist is protected, and maybe I can ask them if they can wait a little bit more when it's safer, when there's a vaccine. But eventually, when we decide for patients, we also have to take into consideration their decisions. Kasi meron talagang patients na kahit anong sabihin mo, they'll do it. But you just have to teach them na lang how to make it safer for them. Kasi meron talagang gagawin at gagawin yun eh. So kung ako yun, personally, I won't do it for myself or not even my mom. But if my patient really wants to do it, I'll just remind her to practice safety. If she can have the acupuncturist swab, o papaswab din siya, so they can be safe uh, for each other. No? Kasi it's not just the therapist or the acupuncturist who is supposed to be COVID-free. Also the patient, baka siya rin pala yung meron and a symptomatic carrier and infect the therapist and then the other patient subsequently. Baka may iba pong question, ay baka may iba pong ano po, opinion on that. I'd love to hear it also if anybody wants to talk about that as well.
Well, actually, you have more questions here, and we are already at 1 p.m. May I ask our panelists if we can just maybe take one or two more here? Okay pa ba, Dr. Salido? Because there are questions here on the future of treatment for OA, regeneration of cartilage, etc. So would you want to venture?
I think that's very feasible, ma'am, especially with science progressing as we speak. And I think that's what we'll wait for from the Lancet. Your Lancet, or yung sa inyo po, ma'am. We will wait for your lectures on that in the future. But that's highly possible and feasible. As Dr. Barba already asked earlier, there's already tanazumab that is in the pipeline for osteoarthritis. So it's not just going to be the Cisadoa, but there'll also be small molecules and biologics for osteoarthritis eventually. And this is an exciting time for medicine and also for osteoarthritis.
Okay. So while there are still more questions and we have no more time, we would like to encourage the attendees to stay a while because Dr. Zamora will answer your questions in the Q&A box, please. So, and these are recorded. This is recorded, so we can send the answers to you. And also, I think it is now time to end the session. We'd like to thank Dr. Zamora for that very timely and very enlightening lecture, especially now in the time of COVID. So now we know, in summary, we know that the core management for osteoarthritis is still non-pharmacologic. We really need to get them to control their pain by exercise, by physical methods, therapy, let them lose weight if they still can, but exercise is a good way to obviate pain. We also need to, we realize now that we do not have to stop managing them during this time of COVID. Dr. Barba also cited, as also we know in several lectures back on osteoarthritis, that there are many appropriate YouTube exercises up to 6 minutes to 10 minutes long for the elderly. So they can follow it in the YouTube. So for now, can we ask the panelists to post in the Q&A box the link for their evaluation and their certificate later. So this afternoon, I think that that's a very well spent lunchtime. We would like to thank Dr. Director Gerardo Ligaspi of the Philippine General Hospital, Dr. Margarita Latluna, Assistant Medical Director, and the Philippine General Hospital IT team for making this webinar possible. Our special thanks again goes to Mylan Philippines, our sponsor. Thank you all for joining us. We hope to see you on November 25 for another very interesting topic, addressing real-life concerns in psoriatic arthritis. Again, thank you and ingat po lahat sa bagyong Ulysses. Good day.